Hey, this is Dr. K from my medical school, and today we're going to talk about DKA and HHS. DKA is also known as Diabetic Ketoacidosis, and HHS is also known as Hyperglycemic Hyperosmolar Syndrome. So let's begin this discussion talking about DKA and HHS and how they compare and contrast to one another. So first, let's focus on DKA. Diabetic ketoacidosis mainly affects type 1 diabetics, though type 2 diabetics are still at risk of developing diabetic ketoacidosis. It's important to understand that DKA and HHS are a spectrum of a disease, meaning that some patients will fit in DKA, some patients will fit in HHS, but there's a good portion of patients that will kind of fit in the middle and have features of both. The mortality rate for DKA ranges from about 2 to 5%. It is characterized by hyperglycemia, hyperketosis, elevated ketones, and metabolic acidosis. Insulin resistance leads the body to seek other sources of energy and causes the breakdown of triglycerides into free fatty acids and glycerol. As free fatty acids are released, they are metabolized by the liver and produce ketone bodies. The presence of high glucose in the blood with the high amount of ketones that are produced from free fatty acids leads to an osmotic diuresis, meaning that there's so much content within the blood that fluid flows from intracellularly to extracellularly into the vessels. This causes the body to think that there's more intravascular volume than there actually is, and the body triggers its own mechanisms of diuresis, leading the patient to become hypovolemic or have a low volume status. There are many causes for DKA. The most common causes include infection, the initiation of steroids, thiazides, or sympathomimetics. These all can lead to DKA. More commonly though, we do see non-compliance as the largest contributor to both the development of DKA and HHS. Now, HHS mostly affects type 2 diabetics. The reason is that type 2 diabetics still have insulin production, so they're less likely to develop the hyperketosis that type 1 diabetics develop. The mortality rate in HHS is significantly higher, of 15%. The key triggering event or feature of HHS is that there's a relative insulin deficiency, meaning that the insulin produced by the body is not enough to compensate for the insulin resistance present. Infection tends to be the most common precipitating factor, very similar to the precipitating factor for DKA. Now, HHS is characterized by hyperglycemia with a lack of ketosis, though, like I mentioned before, DKA and HHS are a spectrum of a disease, and thus some HHS patients can present with a very mild ketosis, which is far less severe than in patients with DKA. Later on, we'll point out the features that differentiate DKA from HHS from both a lab perspective and a history perspective. Now, let's look at the symptoms of both diabetic ketoacidosis and hyperglycemic hyperosmolar syndrome. One of the main features to extract during your history is the onset of a patient's symptoms. DKA tends to present with rapid onset, meaning the patient has felt horrible for the past day or 2 days. HHS tends to have more of a slower onset, meaning they felt bad for the past week or 2 weeks. The common features between DKA and HHS include polyuria and polydipsia. These are due to the elevated glucose and ketones in the blood. Altered mental status is actually the most common presenting feature for HHS, though you will see many patients with DKA present with altered mental status, and it should be worked up completely. In addition to altered mental status, there are other symptoms that patients commonly present with, and these include nausea, vomiting, loss of skin turgor or dry mucous membranes, which is more indicative of a hypovolemia or low volume status. In addition, many patients will have tachycardia and hypotension. Abdominal pain also seems to be a very common presenting symptom that resolves with treatment of the underlying DKA and HHS. Now, let's learn how to diagnose DKA and HHS and how to differentiate between these two syndromes. So let's begin with diabetic ketoacidosis. DKA is characterized by the triad of hyperglycemia, hyperketosis, and metabolic acidosis. The blood glucoses in DKA are greater than 250, urine and serum ketones are positive, and pH of the blood is less than 7.3, consistent with an acidosis. Note that the anion gap on the patient's chemistry is widened to greater than 12. We calculate an anion gap by adding chloride plus bicarb and subtracting that from the total serum sodium. Normally the anion gap is less than 12. In summary, remember the triad of hyperglycemia, hyperketosis, and metabolic acidosis, as these are the key features that will help you differentiate DKA from HHS, help you diagnose DKA in patients. Now, let's discuss how to diagnose HHS. Remember the features of DKA, because you can use them to compare and contrast to HHS to help you differentiate between these two syndromes. First off, in HHS, blood glucoses usually range greater than 600. You'll actually see them around 800 to 900. DKA does not range that high. In addition, the pH of HHS usually ranges greater than 7.3, not consistent generally with an acidosis. Next, there is elevated serum osmolality, usually greater than 320. This is where the hyperosmolar of HHS comes in. This is due to the hyperglycemia present. Another differentiating feature is that there is no anion gap in HHS, as opposed to DKA, which has an elevated anion gap. The one confusing feature between DKA and HHS, again, these are a spectrum of disease, is that rarely HHS may present with trace urine and serum ketones. But again, it's understanding that these diseases are spectrums or ends of a spectrum of disease. So there will be patients that fall in that middle category that have features of both diseases. Don't let this throw you off. Stick to the main features of these diseases to differentiate between HHS and DKA. Now, let's look at some common abnormalities associated with both DKA and HHS. Hopefully by reviewing these, you'll avoid some common pitfalls. First off, leukocytosis is very common in both DKA and HHS, and is usually associated with the elevation of hyperglycemia itself. But if a patient has a white count greater than 25,000, especially with the presence of greater than 10% bands, you really need to think infection. And right away, usually in patients with DKA and HHS, we do a symptom screen. Make sure your review of symptoms covers all the main infectious symptoms, and get cultures and a UA to make sure you're not missing an infection that could have precipitated their DKA/HHS. Next, hyponatremia. Sodium appears falsely low in these syndromes. The reason why sodium appears low is that because of hyperglycemia and hyperketosis in DKA, hyperglycemia in HHS, water flows into the vessels, dilutes out the sodium, causing sodium levels to be lower. To correct for this, you need to add 1.6 to the sodium level for each 100 milligrams per deciliter glucose is above 100. For example, if someone has a glucose of 300 in DKA or HHS, you would, first 300 minus 100 is 200, so I know that there's 200 elevation, So I will multiply 1.6 times 2 because there's two 100s above 100. That will give me 3.2. I'll add 3.2 to my sodium level to correct for this hyperglycemia/hyperketosis. The next lab I want to talk about is Hypertriglyceridemia. An elevation of triglycerides generally occurs in DKA because the body tries to find other sources of energy. This influx of triglycerides in the blood can falsely lower serum sodium as well as serum glucose. Now that we've talked about the features, the symptoms, and diagnosis of DKA and HHS, let's talk about treatment. Treatment for DKA and HHS begins with an initial assessment of the patient. So, an initial assessment, you're obviously going to do the history and physical, but there's some key features you need to focus on. First off, let's look at what you'd first want to order. If a patient looks very septic or sick, you'd want to consider to do an ABG. Make sure to get a Chem 10 to identify an anion gap, order a CBC to look for leukocytosis, order a UA to identify if any infection is present. And then depending on their symptoms, especially if they present with chest pain, consider an EKG. Other things that should run through your mind is to look for other sources of infection that could precipitate their DKA and HHS based on the symptoms that they present to the hospital with. You could do this by first obtaining a chest x-ray or obtaining blood cultures. Once you have done your initial assessment, you need to determine the treatment. And I like to break down the treatment for DKA and HHS into 4 different categories. One category is the insulin regimen, what insulin should be placed on initially, and how they should be transitioned out of the hospital. The second category is IV fluids. This is what fluids to begin treatment with, and then how to change fluids based on a patient's blood glucose and whether they're eating or not. The third category is electrolyte replacement, and the fourth category is the need for administration of bicarbonate. Let's begin with the most important category, IV fluids and hydration status. This is the most important because these patients are extremely hypovolemic. So we separate IV fluids into 3 categories. One is a patient in hypovolemic shock. They are in hypovolemic shock. The first thing you need to do, even before administering insulin, is to provide them with boluses of normal saline. And I will hit them with multiple liters every hour on the hour to make sure they're adequately fluid resuscitated. Once fluid resuscitation is adequate, then proceed on to consider about other treatments like insulin. If the patient is in cardiogenic shock, make sure to find out the etiology for the cardiogenic shock and figure out some type of hemodynamic monitoring, such as an A-line, to make sure their pressures are stable. Next, if it's just they have mild hypotension, then you want to evaluate what is their corrected sodium value, because this will help you differentiate between different fluids. You're going to differentiate between elevated serum sodium, a normal serum sodium, and finally, a low serum sodium. Once you have corrected the serum sodium, if they have an elevated or normal serum sodium, you'll generally start them on half normal saline. If their sodium level is low, then you'll start them on normal saline. For both these regimens, we usually use about a 4 to 14 cc's per kilogram per hour, depending on their volume status. As soon as they hit a serum glucose less than 250, consider switching them to D5 with half normal saline, usually running about 150 to 250 cc's per hour, again based on their volume status. It's important to know what all the medications you are giving them are running in, as commonly insulin drips will run piggybacked on D5. So you may be giving them a little bit too much sugar if they're getting D5 in the insulin drip as well as D5 in their IV fluids. Just be mindful of this when you're providing medications to your DKA or HHS patient. Now let's talk about the insulin regimen. Now there are 2 schools of thought when using insulin in DKA and HHS. One to start sub-Q, other to do insulin drip. I am firmly with insulin drip. I believe patients are better controlled on insulin drip. Nurses are extremely busy, so it's tough for them to monitor these glucoses really closely. So you really need to start an insulin drip just because it generally leads to a quicker hospital course and less complications in the hospital course. The insulin drip starting dose is usually at 0.1 units per kilogram per hour. Now, the key question is, let's say you start someone on an insulin drip. What is your goal blood sugar after 1 hour? Generally, I like to see patients drop by at least 50 to 70 milligrams per deciliter of glucose within that first hour. If they haven't reached that goal, you really need to start titrating up that insulin drip. At the same time, you do not want them to drop down too quickly, as this will commonly precipitate both hypoglycemia as well as hypokalemia. When a patient is able to eat, that is when it is time to think about initiating a multi-dose insulin regimen, including both a long and short-acting insulin. Generally, we start off with a long-acting insulin to provide a basal insulin rate. So there are certain keys to transitioning to a sub-Q insulin. First, the patient's anion gap must have closed or be less than 12. In addition, their blood glucoses should generally be well controlled at less than 200. And though we don't commonly check before transitioning to sub-Q insulin, their pH should be greater than 7.2 in patients with DKA. Now, when transitioning from insulin drip to sub-Q insulin, you have to realize that these long-acting insulins have an onset of action that actually extends about to 2 to 3 hours from when they begin to work. So, when transitioning, you need to keep the insulin drip on for 4 hours before stopping, because if you take the insulin drip off immediately, the longer acting insulins will not have time to exert their effect before the glucoses begin to rise again. So make sure that there's a 4-hour overlap period between when long-acting insulin is started to when an insulin drip is stopped. Let's talk about electrolyte replacement, specifically potassium. Potassium is one of the most important electrolytes in DKA and HHS because insulin causes hypokalemia as it drives potassium into the cells. So if someone has a potassium that's greater than 5, usually we do not give them potassium, but we check potassium very closely every 2 hours and make sure they are not dropping too low. If their potassium is greater than 3.3 but less than 5, I usually place some potassium within their fluids so they're getting a steady stream of potassium throughout the day. And finally, if someone's potassium less than 3.3, hold insulin for that moment and make sure you correct the potassium, because if you don't, the insulin will continue to drive the potassium within the cells. The patient will continue to become hypokalemic and worsen their potassium levels, and you'll have trouble catching up to get them to a normal potassium level. Also remember that magnesium plays a role in potassium replacement. If someone has low magnesium levels, they will be difficult to correct their potassium. So correct both. This brings us to our final topic, bicarbonate. Bicarbonate replacement is a very touchy subject because you should know absolutely never give bicarb for a low bicarb level. I don't care if their bicarb is 8. You do not administer bicarb because it can cause cerebral edema. This is counterintuitive for us because many times patients are admitted who do have a bicarb level that's extremely low, and we do give them bicarbonate when they do not have DKA or HHS. But realize that the treatment of DKA will correct the bicarb because it's the DKA that's driving this metabolic acidosis, causing the bicarb to be so low. The only time you can consider bicarb would be if the pH was less than 7.0. But even then, the prime objective is to treat the DKA, and bicarbonate should really not be given. Now, we've gone over both the features of DKA and HHS, the symptoms, the diagnosis, as well as the different treatment arms you need to consider when faced with a patient with possible DKA and HHS. If you like this discussion about DKA and HHS, give this video a like. If you have any ideas for future videos, place a comment down below and make sure to subscribe. Remember, you can download these videos on iTunes. Just type in MedPulse. And also check out our website at medpulse.org for articles and other videos that you can check out. This is Dr. K from iMedical School. I'll see you next time.
Loving it, loving it. Are you loving it? Yeah, you know I'm loving it.
So if you love it and you can't get enough of it, then put the hand up high right where the other is.
Are you loving it? Yeah, you know I'm loving it. Are you loving it? Yeah, you know you loving it.